Good morning, everyone. For the next 10 minutes, I'm going to present the role of CT in the evaluation of patient before this procedure. Now, CT play a major role in pre-procedural planning. Due to high isotropic spatial resolution, can provide 3D morphologic information on tricuspid valve and adjacent structures, and also provide accurate and reproducible measurements. In order to provide all the information, we need a good quality CT scan, and that means, first of all, that we need optimal and homogeneous opacification of the right chambers. This is a very challenging protocol because we may have artifacts due to competing flow from vena cava or strict artifacts due to high concentration of contrast media in superior vena cava or right ventricle. So we need to perform a triphasic injection protocol. This is a protocol where we inject to the patient different mixtures of contrast and contrast medium and saline in order to avoid all these artifacts. As you can see, the upper images, this is the appropriate opacification of the right ventricles. And you can see in the lower left images how strict artifacts due to high concentration of contrast media could affect the evaluation of the ventricles. And also in the lower right images, you can see suboptimal opacification of the right chambers. Now, the appropriate scan protocol consists of retrospective ECG gating of the whole heart. We don't want with no modulation in order to acquire data from the entire cardiac cycle, and we reconstruct images every 5 to 10% of the cardiac cycle. We keep the slice thickness as small as possible, and also we add a non-gated scan of the venous access from neck to pelvis in order to evaluate the venous system. We pay special attention to patients with atrial fibrillation. In this case, we may require ECG editing, and also we may have metallic artifacts from implanted devices like a pacemaker. And in this case, we apply iterative reconstruction techniques in order to enhance images. So the role of CT is to evaluate the TV apparatus morphology, provide information regarding 3D relationships with adjacent structures, and provide all the necessary measurements for procedural planning. We know that TV apparatus consists of leaflets, annulus, chordia, tentina, and papillary muscles. There is a considerable anatomic variation, and CT can provide information complementary to the ultrasound on tricuspid apparatus morphology. And that means that we can provide some information regarding the number of leaflets or the papillary muscles. Also, we can assess the effect of leads from previous implanted devices on the leaflets. CT also provides information regarding the morphology of the annulus. We know that tricuspid annulus normally is elliptical and saddle-shaped, but in cases of functional regurgitation, the annulus appear more circular and more planar. Now, CT can provide measurement regarding the size of the annulus. This is the most important measurement because accurate measurement of annulus is essential for device selection. We can perform that in a seamless workstation when we perform measurement on short axis view from double oblique reconstruction. However, this method may underestimate the size of the annulus. The most appropriate methods in these cases is to use a dedicated 3D software where we can place seeds around the annulus like we do in the mitral annulus, and this is the appropriate way to accurately represent the complex shape of the annulus and provide accurate and reproducible measurements. We know also that tricuspid annulus is dynamic structure with changes in size and shape, so dimension may change up to 20 to 35% throughout the cardiac cycle. So we need to perform measurements during in systole and diastole. Another important measurement is the size of the right chambers. We know that minimum atrial ventricular size is we need the minimal atrial ventricular size in order to achieve optimal device deployment. So CT can provide information regarding the height of the right atrium and depth of the right ventricle. And this measurement should be performed during systole and diastole. Another information is the relation between right coronary artery and tricuspid annulus. We need to provide the minimum distance between these two structures because during the implantation there is a risk of compression. CT also provides information regarding the optimal procedure of fluoroscopic angles. This is an important information in order to ensure the accurate device deployment and also to decrease procedural time, radiation dose, and the amount of contrast medium. CT also provides information regarding the catheter simulation and trajectory. And finally, CT can provide information regarding the access route, and I'm talking about the venous anatomy, the size of the venous structures, and also to exclude the presence of thrombus. So, in conclusion, CT plays an increasingly important role in pre-procedural assessment for this procedure by providing information for the TV apparatus morphology, by providing information regarding the 3D relationship to adjacent structures, and also provide device-specific measurements necessary for procedural planning. Thank you.
Thank you very much. Excellent presentation, especially about the tricuspid annular measurements and also about the risk of compression of right coronary artery. And my question will be, as you know, a lot of people are now doing TAVI procedures, and we are using Tremencio programs, and we are very close to the aortic annular measurements. Compared to the TAVI measurements, the protocol is the same for tricuspid, or is there any difference for the CT protocol for tricuspid measurements?
First of all, in TAVI case, we target the left ventricles, and in these cases, we mainly target to the right chambers. We also want some opacification of the left ventricles, but it's quite different the target chambers. I mean, TAVI wants left chambers only, and I think and then I think the difference. Another difference is that in TAVI we target the arterial route, and in tricuspid valve we target to the venous system.
I mean contrast, for example, same. The protocol is the same.
Contrast, usually in my department we use monophasic contrast protocol for TAVI, but in cases of tricuspid valve we use a triphasic protocol. First, we have 3 phases. First phase is when we inject around 40 to 50 ml, where 60 to 40% contrast medium saline. Then the second phase, the second phase is a mixture of 40% contrast, 60% saline, and then just saline. In TAVI, we only perform.
We should wait a little bit because of the venous return, and also for some specific valves, we should also see the superior vena cava
from neck.
Thank you very much, Dr. Mourmouris. This was a really outstanding lecture. We're experiencing a period where technology really leaps forward with very high rates, and I think we have photon counting CTs coming up and other enhancements. Do you think that all these will improve our measurements, will make it safer, faster? Will it be more applicable for people with arrhythmias? Where do we expect to see the benefits of technology evolution?
Photon counting CTs is better for, I think, the photon counting CT can provide significant details about the structures who have a better quality. Also, the spatial resolution is very small. I'm not sure about the temporal resolution, because nowadays is about 65 to 74 milliseconds. I'm not sure that it's going to go lower using photon counting CT. But another issue is that using photon counting CT, we can provide less contrast medium, which is very important in these cases, because often patients have renal function problems.
Okay, now we should move on to the two. Thank you very much, Dr. Mourmouris.